In this seventh and final video, I'm going to use fictional ED cases to reinforce the information from the last 6 videos. In these 5 examples, I'll show you how ED documentation changed the final reimbursement. Example number 1, a 30-year-old female with lower abdominal pain, cramping, and vaginal bleeding during the first trimester of pregnancy. You've ordered a beta HCG, type and screen, urinalysis, and a radiology performed ultrasound that shows an IUP at 7 weeks. You document in the MDM that there's an IUP and you discharge the patient home with OB follow-up. Great, this is probably a level 4 chart, but depending on your documentation, this actually may be a level 5 chart. If you're concerned for an ectopic pregnancy and you document this fact and mention that an IUP excludes an ectopic pregnancy, this is higher COPA. Since maybe radiology at your shop takes about 3 hours for ultrasounds, you decide to look at the radiology performed ultrasound images and packs, and you document an independent interpretation of these images, that there's an IUP and no free fluid. This independent interpretation adds to the data category as well. Also, you recommend to the patient that you discontinue her daily NSAIDs and start taking a prenatal vitamin. This is prescription drug management under the risk category. And to support your complexity, you use the following ICD-10 codes. Lower abdominal pain, unspecified. Yes, it has unspecified, but you can't avoid it here. Abnormal uterine and vaginal bleeding, unspecified, and less than 8 weeks of gestation of pregnancy. This documentation likely supports a level 5 chart. Example number 2. A 35-year-old male who presents to the ED for chest pain and shortness of breath. He has a history of factor V Leiden. He went to urgent care first, and then they sent him to the emergency department. You perform an EKG, a troponin. You determine that he is high risk for a PE based on his Wells score, and you perform a CT angiogram of the chest, which ultimately was read as negative. You gave the patient IV Toradol and discharged him home with a diagnosis of chest pain as the final ICD-10 code. This was downcoded to a level 4 chart. Why is that? For the diagnosis, you only put chest pain. Besides chest pain, you should document dyspnea and hypercoagulable state, since that comorbidity influenced your workup. Also, you didn't document that you reviewed the urgent care note from earlier today. You should have documented that EKG had no ischemia, but you didn't use the term independent interpretation, and you did not list 3 elements of the EKG, such as rate, rhythm, axis, ischemia, intervals, etc., so you didn't get credit for that data element. You did not click drug therapy requiring intensive monitoring for toxicity, since you gave the patient IV contrast for the CT angiogram. And finally, you didn't check prescription drug management due to the IV Toradol administered in the ED. Example number 3. A 60-year-old male with a history of alcoholic cirrhosis. He is requesting a paracentesis earlier than scheduled due to abdominal pain and shortness of breath, but afterwards he wants to go home. He doesn't want an IV, just a paracentesis. Let's examine the MDM grid for this encounter. This may be a level 5 chart. For COPA, due to his abdominal pain and distension, if you are honestly concerned for spontaneous bacterial peritonitis, then document this fact since it's an acute intra-abdominal infection, which can be a life-threatening diagnosis. Under the data column, since you're doing a paracentesis, you likely ordered some studies on the ascites, including cell count with differential, culture, gram stain, albumin. These all count as unique tests. You document that you reviewed an outpatient GI clinic note, which recommends that he follow a sodium-restricted diet, and you reinforce that information to the patient. An EKG was performed in triage due to his shortness of breath, and you documented independent interpretation of that EKG. For risk, you performed a paracentesis in the emergency department, so if you remember from lecture 4, this is equal to emergency major surgery, and make sure you document that. And finally, for the final ICD-10 codes, you document shortness of breath, fluid overload unspecified, and alcoholic cirrhosis of the liver with ascites. Example number 4. This one was taken directly from United Healthcare website. See the link in the show notes if you want to read more about it. It's a 37-year-old female with abdominal pain. You order a CBC, CMP, urinalysis, and UPreg. A CT scan of the abdomen and pelvis with contrast was performed, which I assume was normal since she was discharged home, with a diagnosis for right upper quadrant pain. This was a level 4 chart. Why is that? Well, this was likely downcoded since there was no other diagnoses listed, and the doctor didn't document 1, if they had a concern for an acute intra-abdominal infection and therefore lower COPA, and 2, drug therapy requiring intensive monitoring for toxicity due to IV contrast. If there were any other signs, symptoms, or comorbidities that influence your workup, then add those ICD-10 diagnoses, such as vomiting, fever, alcohol use, long-term use of anticoagulants, etc. Remember, list all ICD-10 codes for all diagnoses found and treated during an emergency department visit. Moving on to the last example, number 5. 60-year-old male who tripped on a curb, twisted his right ankle. No loss of consciousness, blood thinners, or anything else like that. He came in via EMS with ankle pain. The patient got an x-ray which showed a non-displaced distal fibula fracture. He received IM Toradol and oral oxycodone prior to splint application, and he was discharged home. This could be a level 3 or level 4 chart depending on how you documented. Let's discuss the documentation that, if appropriate, supports a level 4 chart. For COPA, there's not much here since this is only one diagnosis. But for data, you need to document the EMS as an independent historian, document the independent interpretation of the plain films of the ankle, document a discussion with the orthopedic consultant who says that they will see the patient in clinic tomorrow. And finally, for risk, you want to document prescription drug management since the patient received IM Toradol and oral oxycodone, and definitely document the splint application. As for the ICD-10 codes, you'll want to list the first ICD-10 code or the principal ICD-10 code as non-displaced fracture of the lateral malleolus of the right fibula, initial encounter for closed fracture, rather than just fall or ankle pain. This level of documentation likely justifies a level 4 chart. If you still want to know more about documentation, billing, or reimbursement, ACEP and EMRA have teamed up to provide a free online course to take a deeper dive on these topics. It includes these 11 modules. It's one of the best resources available for these topics. Please note that you must be an ACEP or EMRA member to access this course. The link is in the show notes. Hopefully the last 7 videos help you become a more informed physician about the importance of your medical documentation. If you enjoyed this documentation series, I humbly ask that you like this video, subscribe to my channel, or just share the playlist with your colleagues. Thank you very much.